And we will start with the first presentation. That will be Dr. Claudia Priglinger from Munich, and she will talk about LHON treatment in children. And she's a pediatric ophthalmologist and neuro-ophthalmologist from Munich joining us, and we love to hear her talk.
So a warm welcome from Munich to my presentation on treatment of LHON in childhood, and I would like to thank the SOE for inviting me to share our experience on this issue. These are my financial disclosures. Before we talk about LHON in children, I think it's necessary to share some data on what we know about adult onset LHON. So typically LHON is perceived as a disease of young men because the typical age of onset is between the second and the third decade, and 80% of the patients are male. LHON in 90% of the cases is caused by point mutations in the mitochondrial genome, with 70% being due to the mutation 11778, which is the most severe one and causes the most severe course of the disease, and the mildest course we have with the 14844 mutation. When LHON starts at an age of younger than 12 years, it's defined as childhood onset LHON. And this was not known to exist until Barboni in 2006 described his first case series of 14 patients. And altogether, we have now only about 137 cases described in the literature. From these data, we know that the LHON in childhood is an atypical LHON, not only in terms of the age of onset, also because male preponderance is not as pronounced. So we have to keep in mind that girls can be affected by LHON as well. Also, the clinical course appears to be different. From adults, we know that they experience a subacute unilateral vision loss, which is painless, and vision declines rapidly within half a year to 1/50 or even less, and then reaches a plateau for the rest of their life. And in children, there are slowly progressive and insidious courses as well. So this has to be kept in mind when dealing with children with childhood onset Leber's hereditary optic neuropathy. Also, unilateral courses are possible, but the good thing is that the children have a better visual prognosis overall. So adults reach a mean visual acuity of 1/50, and the children at least of 0.2. Another good thing about LHON is, at least for the adults, that we have a treatment. So in 2015, the EMA approved Idebenone for treatment of LHON. And benefit was proven for carriers of the 11778 and the 3460 mutation. It's recommended to begin the treatment within the first year after onset. For children, however, this is an off-label treatment. And before we decide to do such a treatment in children, we want to know two things. First of all, does it harm the children? And second is, do they benefit at all? If we look at Idebenone treatment in adults, what can we expect? So the mean best corrected visual acuity in the natural course is about 1/50 or even less after 52 months. So they are all off charts. After treatment with Idebenone, 50% of the patients were reported to respond to the treatment. So how was response defined? Response was defined as a gain of more than 2 lines after 24 to 30 months of treatment. The mean gain of visual acuity in total was about 19 letters, which equals to 4 lines. Better recovery was observed when the vision did not decline too deep. And finally, about 56% of the eyes in the natural course and only 30% of the eyes after Idebenone treatment remained below 1/50. So to answer the question, what should we do with children? Should we or can we treat them with Idebenone? We went into the MitoNet registry, which is Germany's biggest database on mitochondrial diseases and found 61 patients with an onset at a very young age. We subdivided them into two subgroups. One subgroup was the typical childhood onset LHON with an onset at an age of younger than 12 years. And the second subgroup was also with an earlier age at onset. They were only 12 to 16 years old when the disease became manifest. And both were subdivided in a natural course group and in an Idebenone treated cohort. Looking at the demographics, you can see on the left-hand side the childhood onset cohort and on the right-hand side the early onset, the teenagers. And it's very obvious that in the childhood group, we have about 1/3 of children that were girls. So please always keep in mind that girls can be affected. And 80% have an insidious or slowly progressive, so that's an atypical mode of onset. Whereas in the teenage group, and this is also remarkable, almost all affected were male. The distribution of the LHON mutation was just like in adults, and another peculiar finding was that in both age groups, we didn't have a single patient with the most benign mutation in natural course. Probably, or maybe because the prognosis in the long term is so good, they didn't even enter the registry. To answer the first question, can we treat? So we found that Idebenone was very well tolerated. Treatment didn't have to be interrupted in a single patient because of side effects. Second question, should we treat? So there are many measures that can be taken. We decided to determine mean final best corrected visual acuity and two parameters of practical relevance, of functional relevance. That was the proportion of severely impaired patients and the proportion of those with a very good visual acuity. So if we look at the natural course, the teenagers, interestingly, were almost as bad in the long term as the adults. They did slightly better, which about 2 lines, but still very bad. The children, however, as reported in literature before, were about 7 lines better than the at-onset patients. So the visual prognosis, if you look at the different LHON mutations, also like in the adults, was critically dependent on the underlying LHON mutation, with the 11778 mutation having the most severe course. After treatment with Idebenone in our group, none of the teenagers overall had a benefit from the treatment. So they were still as bad as in a natural course. However, and that was interesting, the children improved in their mean visual acuity, especially in the 3rd year of treatment. Looking at the proportion of eyes with a very bad visual acuity, which is important in patient counseling because they always want to know whether the child will be legally blind or dependent on low vision aids. We could see that the teenagers in long-term natural course did a bit better than the adults, with only 70% of the patients remaining beyond that level, and only 30 to 45% of the children in the long-term natural course in the most abundant mutation. When treated with Idebenone, again, the teenagers did not benefit in this matter. However, and that was interesting, none of our children was still beyond 0.1 decimal after 36 months of Idebenone treatment, but of note, it's only a very few cases reported here. Looking at the proportion of eyes with a really good visual acuity, that means independence of low vision aid or even being able to drive a car, 11% of the eyes in young teenagers reached this point in the long-term natural course, and 20 to 30% of the children. After Idebenone treatment, again, we couldn't see an improvement in the teenagers, but again, we found an improvement in the children after 36 months, that's 3 years of Idebenone treatment, with 50% of the eyes being better than 0.5 decimal in the most malignant LHON mutation. The interesting finding also was that the clinically relevant recovery, that's the main measure often taken in clinical studies, defined as a gain than more than 2 lines from nadir, was comparable in all age groups. And this was irrespective whether we take a milestone of 2 lines or 3 lines as a measure. So the rate of clinically relevant recovery is comparable, and it's also comparable to that was found in adults after Rexone treatment, where they reported 50% after 30 months of treatment. However, the children do much better than the adults. So how can that be? And this becomes clear if you looked at the trajectories of best-corrected visual acuity in the long term. The children here in orange, because it's logMAR visual acuity, it's above. The children are in blue because it's logMAR, they are at the lower level. In the whole course of the disease, don't lose as much visual acuity as the teenagers do. So they experience a much milder course of the disease. And the impact of that becomes clear if we look at the range of logMAR visual acuity. So there are certain milestones available, like hand motion visual acuity, counting fingers, 1/50 off chart, or legal blindness, and the independence of vision aid. And that's not the whole end of the spectrum. And if we put the course of visual acuity of our children and our teenagers into that scale, we can see that the teenagers are ranging in the very, very low visual acuity group. So if somebody with a visual acuity of logMAR 2.3 improves about 4 lines, he's still only at counting fingers, which is defined as 1.9. So this might still be an improvement, but it's just not of real functional relevance in our world. Taken together, we made the observation that if LHON begins at a very young age, there are maybe 2 different groups of the disease. So childhood onset on LHON appears almost to be a known entity with a very benign course of disease. 1/3 are girls, an incident slowly progressive course of disease. And often they have a family history that's positive, especially in our girls. Often the mother was affected as a child. The early teenage onset group, where the patients are not much older when disease begins, are in 90% of the cases male, often also have a positive family history, and they appear to experience a particularly severe course of the disease. So taken together in our small patient cohort, children had a benefit from Idebenone treatment in all aspects. The teens, however, not as far as the visual acuity measures that we took are concerned, but they still gained more lines, more often, more than 2 lines than if they are not treated. So taken together, as far as our data can be interpreted, Idebenone treatment may positively influence improvement in vision, especially after a childhood onset to levels of functional relevance. The clinical recovery, however, the rate was comparable in both age groups, and the extent of vision loss at nadir, therefore, significantly determines the final outcome, may be important for patient counseling and the prognosis of the patients. The major challenge, however, for us ophthalmologists in the first line is to establish the right diagnosis. And I think that LHON should be added to the differential diagnosis of a medically unexplained vision loss in children, because young children can develop coping strategies. They have slowly and insidious causes of the diseases, so they may adapt to the vision loss very easily, especially if they have unilateral causes. And please always keep in mind that girls can be affected as well. So I want to thank you for your attention and thank all the colleagues from my department who helped collecting this data. And at the same time, I'd like to invite you to the EPOS, which will be held in Munich in this fall. Thank you.